Hello, everyone. My name is Matthew Adams. I'm the clinical manager for Apollo MedFlight. My name is also known as Ducey. You know how we acquire nicknames through the years. I've been a paramedic for approximately about 22 years now. About 8 of those years have been on the flight line. We're going to continue on with this training in didactic assessments, talking about airway management, assessment principles, and some pharmacology as well to go along with that. The thing we need to understand about airway management is that with the airway, specifically taking a patient's airway is the highest liability that we will ever do as clinicians, and regardless of what the clinical setting may be, whether that's pre-hospital, scene settings, or an intrafacility environment, it will be the biggest liability. So that said, we need to make sure that we are experts in managing airways, recognition of certain things, and avoiding certain pitfalls, and we're going to discuss all of those things as we get through this presentation. So let's discuss our objectives here. Let me get the device for it. There we go. The objectives, we're going to describe the proper steps, describe the indications for establishing an artificial airway, and we'll discuss techniques to securing, which can be a skill on its own. Evaluating is also another skill on its own, and then of course monitoring during our transports. We're going to describe some medications used to facilitate airway management. The things we need to understand is that a lot of times people think that RSI, crash airway, and medicated assisted intubations are all the same thing, and they're not. Specifically, a common misconception on that is that RSI and crash airway are synonymous, and they are not. There are different approaches. When we actually think about rapid sequence intubation, it's actually a delayed sequence, as there are 7 specific steps that have to be performed. So the rapid sequence part of it is the onboarding of sedation followed by the paralytic. And we'll discuss those here soon. And then we're going to talk about management strategies for unique and difficult airways. Also, we will have a specific skills session where we will accompany this didactic presentation along with our training at a later date. Okay. There we go. Little pause in our screen there. Okay, so little introductory there to it is airway is the central priority. That's why it's the letter A in the ABCs for a specific good reason. Airway patency and prevention of hypoxia is going to take precedence over all other clinical considerations. And of course, it's the defining skill of the clinicians the world over. All right, so just a little bit of review when we're talking about anatomy. You'll look over in the right-hand picture there, the pharynx. The pharynx is the, let me see if I can get my mouse to come around. There we go. The pharynx here is a U-shaped structure. It conducts food to the esophagus and air into the larynx, the trachea, and of course into the lungs. Then our epiglottis. The epiglottis is this tiny little leaf-shaped structure coated with a mucous membrane. It prevents aspiration by covering the glottis during swallowing. And then the larynx, when we're looking at the larynx there, we've got 2 different views. The larynx contains the vocal cords, as we well know, and it regulates airflow to and from the lungs for good phonation, which phonation, by the way, is a good indication of whether the airway is adequately functional or not. All right. Some more anatomy that we're looking at, specifically the glottic opening, the tongue, the epiglottis, the vocal cords, the posterior cartilages, and these are all the structures that form the glottic opening, and they are the key landmarks used to facilitate intubation. All right. Now, we're going to take an airway assessment using the ABCDEs in isolating that approach in this airway itself. In other words, a lot of times we take this airway, breathing, circulation, disability, exposure to full general medical assessment, but we're going to take that approach just to the airway, okay? And we'll see why here. You know, A begins with approach. Our normal findings are going to be, you know, level of consciousness, absence of distress, the control of secretions, the ability to phonate with a clear voice, as I mentioned. Some abnormal findings would be, of course, if they're injured, confused, combative, unconscious. One should think that if there is an airway compromise with confusion, that they're pending respiratory failure, unless we can quickly rule out hypoglycemia, which we can do that with bedside point of care testing. Of course, we'll be looking in the mouth, inspect the airway for blood, vomit, secretions, broken dentures, loose teeth, or foreign bodies. Simple BLS adjunct that we'll discuss as a review later on is that we can place an NPA if there's no contraindications or an OPA and begin BVM ventilations. And we'll note any facial deformities while we're doing that. If there's facial deformities or there's difficult with ventilating with the BVM, it should question which airway approach we are going to take, and we'll further delve into that later on. Of course, the neck, we're going to examine the neck. We're going to palpate the carotid arteries, note the tracheal positioning, observe for JVD, sub-Q air, injuries, hematoma, or any edema. And of course, we want to note the anatomic indications, such as posterior. A lot of times you'll hear that term, well, that patient was really anterior. And in all actuality, the patient still has a normal anatomic landmark. It's just that they have a recessed jaw that will actually give them that anterior appearance. Of course, our B in breathing in the airway, we're going to inspect and observe for adequate chest rise, looking for open wounds, flail segments, contusions, deformities, or any diaphragmatic breathing. Okay. In our palpation, we'll be looking for any tenderness, bony crepitus, the presence of subcutaneous air, and of course any asymmetrical chest wall movements. Then auscultation, listening for the presence of a pneumo or a tension pneumo. That may actually change the airway management plan there altogether. Because one thing we want to remember that when we introduced endotracheal intubation and start ventilating with a BVM, we've changed the natural physiology of breathing upside down on its head and start positive pressure ventilation. So even under normal circumstances in the environment of intubating, we can going from a negative to an extreme positive can possibly precipitate the chance of a pneumothorax taking place. So just be mindful of that, and that's including even using a ventilator. Okay, so always be prepared. Circulation is certainly indicated in the airway management status. An assessment of their hemodynamic status will actually provide additional information needed to perform the airway management plan. It may alter specific medications we may want to utilize. Hypotension or even marginal hemodynamic instability may require a reduction in the med dosage or the use of alternate meds to help facilitate. Specifically medications that we may see common in the interfacility transport setting is Diprovan. It can cause hypotension. Versed is another example of, even though it's not a venal dilator in of its own, due to the relaxation, it can relax the vasculature wall and then cause the vessels to dilate. And so if there's a preload issue, you certainly want to be careful what medication you're going to be introducing. A good thing to monitor, as we all well know, is the mean arterial pressure. Remember that the mean arterial pressure is the full cardiac cycle from systole to diastole. And that's what we need to be looking at for circulatory status, hemodynamic status. The best way to do that, to calculate that, there's a couple of formulas out there. One would be to double the diastolic and add its sum to the systolic and divide by 3. So, for example, if I had a blood pressure of 83/50, you'd start with your diastolic. 50 times 2 would be 100. Then you'd add your systolic, which was 83, and it'd be 183. Then divide by 3, which would give us 61. So that said, anything below 60 over a period of time can cause end organ failure. Okay? And of course, airway assessment, and we're all familiar with the neuro exams that we would do. A neuro exam is definitely important as part of the airway assessment, our ABFU scale. Okay, we should accomplish this, determine if the patient's conscious, alert, and oriented to time, self, place, and event, or if their GCS is altered. We want to assess that as well, their pupillary response and the symmetry of their pupils, the presence of extremity movement and focal neurological signs. We need to accomplish that as well prior to administering any medications to help facilitate airway management. Because again, you know, some of that findings may have some contraindications to the medications we may decide to deliver, specifically in that case, neuromuscular blockade agents such as succinylcholine. We'll talk more about that. Of course, we're even going to expose as well in the airway assessment. We're going to want to remove the patient's clothing so we can get a good direct look at the neck. Obviously, anything that would be covering the head, such as hats, and of course, looking at the chest. You know, adequate lighting and environmental control may be necessary to ultimately assess and manage the airway. We may have to move to a different location, depends on the situation or logistical environment that we're in, such as an ambulance, ditch, or even a resuscitation room. Okay. So identifying a difficult airway, these statistics are straight from the JIMS journal magazine. So the odds in the OR, they can't ventilate, can't intubate, even though these statistics are relatively low, one failure is too many. Imagine that being your patient or your family member, okay? One failed airway is too many. And typically, a lot of times when we think of failed airway, we think of it as the clinician's fault, and we need to differentiate between that. It's not necessarily always the case, okay? A lot of times our attempts is going to be 2 attempts from the primary clinician, and the most experienced provider is the one who needs to encounter and step up and take that airway. And if they can't get it under 2 attempts, another experienced provider would be to take another attempt. So it's not this person gets 3 attempts and that person gets 3 attempts and that person gets 3 attempts. That's not how that works. If we can't get it, I would say in the first 2, it's time to think of something else. Okay, you got to remember that the lungs do not care where the oxygen comes from. All right, and then elective OR cases, 3 or more attempts occurs in 1 in 4%, and the ER, more difficult, 10% of those cases, which is a lot of times where we're going to live is in our interfacility area. Now imagine that in the field. Some of you paramedics sitting through this course can probably relate to that with difficult intubations in the specific field setting, basements, ditches, rotor wing landings, and so forth, okay? Imagine if this is the patient that you had to walk into, all right? The difficulty may be due to some inherent patient attribute or a clinical condition such as, you know, maybe they have obstructive sleep apnea or recessed jaw, as I mentioned earlier, or maybe it's the logistical situation or environment that you're in, okay? So identifying a difficult airway, it's very important that we identify the difficult airway, okay? Specifically, we can, and we're going to talk about some specific methods and so forth, but, and there's several of them out there, but we're going to touch on just a few. And again, you know, if I don't mention everything here, please do some research, you know, expand your knowledge. But BVM ventilation is the primary rescue ventilation technique used to prevent hypoxia after failed intubation attempts. So that being said, it's really essential to anticipate difficulties prior to the administration of neuromuscular blockades, because that may hinder and then complicate our airway plan. So there's difficult laryngoscopy and intubation. Okay? The inability to position the patient's head can actually reduce the visibility by almost half. So on the clinician aspect, that can lead to fatigue, a reduced glottic view, and then possibly flawed decision-making in your attempts. So we're going to talk about the Mallampati score. The Mallampati score It's typically ideal for a patient who is conscious, awake, alert, and oriented that we plan on intubating, depending on what type of setting that may happen. So what this does, it views the posterior oral pharyngeal structures that reveal the relationship between the mouth opening, the size of the tongue, and the size of the oral pharynx, which dictates access for oral intubation. Sometimes it's not ideal because it requires the patient to sit up. As I mentioned, they got to be awake, open their mouth as far as possible, and protrude their tongue out also as far as possible. So we can see in the picture here where class 1 and class 2 have lower failed rates, whereas 3 and 4 will obviously have the higher failed rates. We're looking at 4, we can only see the tongue. Looking at this other method here, it's called the 3-3-2 method. Okay, the first 3 addresses the oral opening, so the patient should be able to accommodate 3 fingers between the incisors and accommodate 3 of their own fingers, not your fingers. Okay, don't stick your fingers in patients. Any less than 3 may be difficult viewing the glottis or inserting the airway device. So for example, I have 3 here and I have less, more likely that I'm going to have a limited glottic view. The second 3 addresses the space available to accommodate the tongue during laryngoscopy. This is what the picture you see here, distance from the tip of the mentum or the chin to the hyoid bone. Less than 3 finger widths will have greater difficulty, again, indicating a more recessed or some sort of mandible issue that they may have, which is what we commonly refer to as an anterior airway. And then the 2 in the 3-3-2 identifies the location of the larynx in relationship to the tongue. The distance of the base of the mandible to the top of the larynx greater than 2 finger widths will have greater difficulty. And again, all measured using the patient's fingers, not your own. All right. Identifying extraglottic device placement. So extraglottic devices or supraglottic airways are used when a BBM ventilation intubation has failed. And as critical care clinicians, the supraglottic airway should be our backup device, but there are times where that's the only option you may have, and there are times where the surgical cracothoracotomy may be the only option you have as well. So as with mask ventilation, identifying likely failures with a supraglottic or extraglottic device will also drive the airway management plan and possibly limit your decision thinking on administering neuromuscular blockades. So these should be considered when evaluating extraglottic device success. So identifying a difficult surgical airway, okay? Surgical airways are typically the terminal end of most airway decision-making or algorithms, not always the case. These evidence of neck surgery, soft tissue distortion, laryngeal trauma, among others, should also be identified in factoring the management approach. Okay, so now let's talk about the indications for an advanced airway. All right, it's summarized in these 3 findings here. Failure to maintain or protect the airway. Patients may not be able to protect the airway from aspiration of secretions, blood, gastric contents, or an obtunded patient due to the lack of muscle coordination to direct those insults away from the airway. So BLS in that aspect should be only used as temporizing measures. Okay. Well, we have a current failure despite ventilation and oxygenation, which you got to remember that ventilation and oxygenation are 2 different concepts, and we'll discuss that in a later presentation. Sometimes an airway is placed to facilitate ventilation and oxygenation rather than simply to protect the airway. For example, maybe a patient with chest trauma. They may oxygenate poorly due to the chest wall movement being limited, and of course the alveolar dysfunction that may be present as well. And then of course clinical manifestations that will lead to the above mentioned in this slide here, some patients may present with an intact airway, adequate oxygenation and ventilation, but still require intubation regardless. An example I can give you of this would be a burn patient due to an inhalation injury causing swelling from that superheated air, causing all of that blood to pool, and the lung injury as well, which would result in hypoxia. So we would definitely want to be in there early, that's for certain. All right, so the airway management plan, okay? Transport teams, the focus here, we should, as transport teams, we should utilize a structured, comprehensive approach to airway management. You know, we should be well trained and proficient in techniques, the medications, and of use of BLS devices, supraglottic airways, and of course surgical approaches as well. What we're trying to avoid is we don't want to add insult to injury. We don't want to add hyperventilation, hypercarbia, hypocarbia, and hypoxemia by delays. Okay, we need to move with purpose and be very, very quick. That's why we perform these skills quarterly for not only the clinical knowledge of it, but for that muscle memory of practicing. With monitoring devices, particularly troublesome airways may need multiple equipment set up and readily available. So what you should have out when you're getting ready is all your medications drawn up, ready to go, your primary approach for airway device, and then which would be your instrument for the airway, your laryngoscope blade of your choice, OPAs, NPAs, and a BVM, a suction up and ready to go that's fully charged and functional or has power to it, Yonkers and endotracheal suction right there available to you, and then of course a backup airway plan, and you need to have plan B and plan C as well. So if you have a supraglottic airway device as a backup plan, you probably ought to have your surgical cric kit right there available too. And not to mention, as I said, that the going from an extreme negative pressure to an extreme positive pressure when intubating, we probably want to have the means of doing a needle thoracotomy available to us as well. So going back to the basics here, our procedures, and we'll have skills lab, okay? OPAs and NPAs displace the tongue forward and away from the posterior pharynx. Of course, BVMs, you have one and two person techniques, excuse me. The NG tube or gastric tube is got an open port, or in other words, vented for flight. That way, it'll reduce gastric insulation, and also, just on a side note here, be mindful if it's the case of coagulation lab values before introducing anything in the patient's nasal airway. You don't want to cause some small lacerations and then putting some issues in your airway as well. And remember that high INRs, et cetera, such as your PTTs and so forth, they're actually contraindicated in the placement of a nasogastric tube. And then just use your oral gastric tube instead. And of course, cricoid pressure minimizes gastric insufflation and also helps to occlude the esophagus. So the instruments that we have here for laryngoscopy, okay, endotracheal intubation provides considerable protection, as we've mentioned, from aspiration, and it's going to allow for a controlled and precise ventilation. It reduces the work of breathing, right? Remember that work of breathing has to do with resistance, okay? And then it's going to maximize oxygenation as well. So when we're looking for patency, maintenance, and protection, if we summarized it in 3 words there. Of course, as a review of the blades and handles there, the tall, thicker one is for an adult, and then the two smaller, the tall skinny and the small fat one is more for the pediatric aspect, but actually you can use them in all of them. Just more of a preferred technique. Looking at the blades, the blades on the left, your straight blades, or in other words, your Miller blade there, you have some size 00 up to size 4. Okay, your size 00 would be typically for your preemie, size 0, your neonatal patients, size 1, infants, and down the line, really when you're getting up to typically a size 3 or 4 for the adult patient, just depending on weight. Then of course your Macintosh blades or your curved blades there be another preference that you may have. So what you need to understand the difference between the two. The Miller blade or the straight blade actually lifts the epiglottis directly, okay? It's simply a straight approach, and it lifts all the glottic opening up and anterior. As with the curved or Macintosh blade, it actually goes into the space called the vallecula and lifts the epiglottis indirectly with more of a sweeping of the tongue type action. And then a lot of times both approaches may have to sweep the tongue as well, but typically the longer the Miller blade, the less sweeping of the tongue. And the Miller blade, like a size 4, your horse looking blade there, is really good for extreme multi-systems trauma and getting everything into view and out of the way. It just depends on what your preference is, okay? And of course, oral tracheal intubation and lining the axis. This is optimal if no spinal injuries are suspected. So we have the oropharyngeal axis, the pharyngeal axis, and the laryngeal axis, as you can see, where the base of the mandible and the tragus of the ear all line up with the anterior aspect of the shoulder. Okay, that's typically where you want to be. And this is really what they call that sniffing position as well. Okay. Just a little quick second view at the glottic opening here. As you can see, the top portion here, let me get my mouse so we can see things. Where you see, this is where the vallecula space is, where the Macintosh blade actually inserts itself in here, and you can see when you're instrumenting the airway the full view of the epiglottis, whereas the Miller blade actually grabs it right here. Then of course these are the vocal cords here and the adenoid cartilages here. So this is where you're specifically going to be passing the endotracheal tube. Okay. Probably a good review for most. All right. So here's another good tool for assessment and identifying a difficult airway as well. This is has more of an advantage than the Mallampati score. The Cormack and Lehane can be done when a patient's unconscious as well. Of course, grade 1 is the visualization of the entire glottic opening. Grade 2 is the adenoid cartilages, as we see there, or in other words, the posterior glottic opening. And then I'm looking at grade 3 is the epiglottis only, and then grade 4 is only the tongue. So we must be experts in optimizing limited glottic views and utilizing additional techniques to help carry out our intubation. External laryngeal manipulation, okay? What this do, if the vocal cords aren't visualized or if they're partially visualized, this is actually going to improve the glottic view. And when you do these techniques properly, this can actually improve that laryngoscopic view after you instrument the airway by up to 1 Cormack-Lehane grade, okay? Just remember that burp, what you would need to do is grab your partner's hand, okay, and put that partner's hand on the patient's trachea there, and you go backwards, upwards, right, and you leave their hand there. That way it keeps it into view, okay? Of course, the Selleck's maneuver as well. Some texts say that it's no longer indicated. What I would say to do is, do whatever works without injury to the patient using proper form and technique. And of course, the tracheal tube introducer, otherwise known as a bougie, okay? It's got what they call a caude tip there at the ends. It's slightly bent. And as the catheter advances, the tracheal rings may be felt as the tips click, 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 and ends over them. So you're feeling that click, 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 then stop because it hits the carotid there. It can be single operator use when you preload an endotracheal tube, which is not a sterile, or dual operator use where it's more sterile, where two clinicians are performing a skill, and that skill will be demonstrated and performed as part of our skill stations. Okay. Video laryngoscopy, what we have here, this is kind of old technology. We currently are using what they call a king vision. So it uses a small video camera and screen or a lens prism or even a combination to visualize the glottis. You know, the approach is strictly midline. There's no sweeping of the tongue at all. And then that ET tube is indirectly guided, so to speak. This can be very useful in limited views or poor logistical situations as well. And some of the disadvantages, though, specifically are the cost. But it is a tool we use, a king vision, and it's part of our equipment and skills practice and testing we'll follow up with shortly. Now, the extraglottic devices, as I've mentioned, specifically the ones listed here, the one in the picture there is called the King Air. It's got a large proximal balloon, and it seals the oral pharynx. And that smaller distal cuff seals the distal aspect upon the position that you play. It's actually placed blindly. So this is what that does with those two balloons. It seals off the trachea. It's not directly in the trachea, but it isolates it so that air can be shoved straight into the trachea and then into the lungs for oxygenation. So surgical airways, a lot of times this is a last-ditch effort when all the other means have failed, or maybe there's no other option available. Okay, it's contraindicated in patients less than 10 to 12 years of age due to that more pliable, smaller mobile larynx for that reason. Okay, we will practice the skills. There are several general global approaches to on the technique, and we will have a skills lab and how we would practice that. But to review, it's you can have a vertical incision followed by a horizontal incision. That way you can poke that tracheal membrane, okay? And then you can just simply have a horizontal incision, but you got to remember where your vasculature is, okay? Horizontal incisions are usually not a good idea, okay? And so you want to just remember that when you're locating the landmark, you're going to put that patient's nose in line with their chin, in line with that thyroid cartilage membrane here, that little V that you can feel. Walk your fingers down and feel that in depression that you feel. And that's where you will find the cricoid membrane, which is the structure that we're going to pierce to place an endotracheal tube. And you don't need anything greater than a size 5.5. It's the best size that you can use. Secure with tape as you would, and then ventilate, watching everything else that you would normally watch, compliance, end-tidal CO2, and so forth. Okay. Needle cricothyrotomy it's not a definitive care. It's only temporizing. It's primarily for our pediatric patients. Typically what you do is you would grab the size tip of a size 3 ET tube, and once you've made your needle cric, you put that size 3 ET tube tip into that angiocath, which would give you a connection to ventilate that patient. And the thing to be mindful of with this is to watch the compliance or the chest rise of the patient. You know, sometimes you may actually have to push those lungs back down. So be careful that we make sure that air is able to, the patient's able to exhalate as well. So with post-intubation management, okay, unrecognized esophageal intubation is a significant threat to the patient. Okay, death or permanent brain damage may occur if you don't verify. So all these methods, if available, as possible, need to be utilized. I know some may not always be utilized in the field, such as your chest x-ray and so forth. But you want to remember that The most reliable method in confirming endotracheal intubation is end-tidal CO2 waveform reading in capnography. Whereas a chest X-ray determines position, the end-tidal CO2 and waveform capnography determines that you're even in period. So, and you want to remember that as we'll talk about capnography in a later presentation, it has a direct relationship with cardiac output. So you want to maintain an end-tidal CO2 between 35 and 45 millimeters of mercury. Of course, verification of depth, a good rule of thumb is tube placement is the tube size you utilize times 3. Will typically give you a good indication on what your depth should be, okay, at the teeth. And of course, for familiarization, it's usually 2 to 6 centimeters above the corona. Adult males, 23 centimeters at the teeth. Adult females, 21 at the teeth. And of course, using Broslow tapes can be used as well in your pediatric patients. And of course, securing the tube is important. Now let's talk about post-intubation complications. The immediate ones are changes in respiratory dynamics, as I mentioned earlier, from negative pressure to positive pressure. So this can precipitate hypotension caused by the increased thoracic pressure or convert simple pneumos to tension pneumos, okay? So be prepared to perform a needle thoracotomy if this is something present, okay? Of course, you'd be falling down that DOPE acronym, displacement, obstruction, pneumo, equipment failure, and so forth, okay? Now with rapid sequence intubation, let's get into this just a little bit, okay? The goal of rapid sequence intubation is to achieve optimal intubation conditions with a rapid onset of sedation and paralysis. That's the rapid sequence aspect of it, while reducing complications. It is a well-planned, methodical process with the patient, medications, and equipment all prepared in advance, okay? Looking down this list here, head injuries, of course. Trismus is your lockjaw. Depends, uncontrolled seizures. Let me clarify the uncontrolled seizures. We don't give paralytics to control a seizure, okay? We would give neuromuscular blocking agents after the sedative to help protect the airway. If we're using paralytics to control seizures, you've got to remember that they're still seizing in here, okay? So not to be misunderstood that paralytics we use to control seizures, but to protect the airway would be the idea behind that, okay? Also, intact protective airway reflexes due to some sort of laryngeal spasms or something. Neuromuscular blockade contraindications, intubation likely to fail. This would be likely due to massive facial trauma or airway injury, possibly. A medicated assisted approach may be preferred in order to preserve the patient's ability to spontaneously breathe. And those are some things that we need to keep in mind here. There may be some times where we want to preserve the patient's ability to spontaneously breathe, whether that be a patient who is in DKA for compensatory actions, or whether that's a patient who still has intact airway reflexes that we don't want to completely remove from that patient, so they still have those abilities as well. All right, so preparation. So assess for difficulty in both intubation and ventilation. So our med doses and sequences are predetermined, okay? Where the rubber meets the road on our specific medications is you need to understand the concentration that's in that volume. You need to be able to look at that volume and that vial of a medication and realize, okay, there's 10 milligrams of a specific drug in 100 cc's and be able to quickly identify how much volume you need to pull up. And it's during the heat of the moment, it's not time to figure that out unless you're quick in math, okay? When you're looking and checking your equipment, when you're looking at your medications, and a good rule of thumb is look at all the medications, specifically the ones that manage the airway, and memorize how much you would pull up to have a patient's airway established, specifically in your pediatric population, because the drug dosages are always based off their weight, okay? And of course, we'll have monitoring of the rate, rhythm, blood pressure, pulse oximetry, and tidal CO2, and so forth we want to have available. So pre-oxygenation. Okay, you want to remember that when we think about the partial pressures of gases, okay, remember that nitrogen's got 79% in the atmosphere, and we'll talk about that in our flight physiology discussion. Nitrogen is greater in the ambient air than oxygen, so we're going to want to use a high-flow non-rebreather mask for approximately 3 to 5 minutes to get that nitrogen washout. Okay, you want to remember that I mentioned that atmospheric gases of nitrogen are around 79%, whereas the oxygen is, we all know, 21%. So the density of air is greater in the lower atmosphere and decreases rapidly as altitude increases. So that would be a little tidbit for your flight physiology that we'll discuss again later. And of course, our pre-medications, of course, positioning, let me back up. Positioning, going to make sure that if they got a suspected spinal injury, that they must remain in a neutral position there. Non-injured, we can put them in that those axes that I mentioned, in that sniffing position. Then, of course, pre-medications. You want to remember that there are certain acronyms out there: lidocaine, fentanyl, atropine. If you remember the term load or FOD, let me talk about them. Load, lidocaine. O for opiates, A for atropine, D for a defasciculating dose. Let me talk about each of these now. Lidocaine, remember that blunt sympathetic response and helps to reduce ICP considerations. The O for opiates, the fentanyl, will also decrease the pain response as well and blunt the sympathetic response to laryngoscopy. Okay, but you want to be careful when you're given fentanyl in this aspect, because it can cause some chest wall rigidity if given too quickly. Of course, atropine is more indicated for our pediatric patients because of the stimulation of the vagal nerve when we instrument the airway. And then D would be a defasciculating dose of a specific neuromuscular blockade, such as succinylcholine. Okay, there's some controversy about succinylcholine causing fasciculations and so forth, and specifically in patients with neuro issues or head injuries, which if you're given the lidocaine, it's a non-issue anyways. However, when you want to give a defasciculating dose, you're going to give 10% of the original dose indicated. So let's say I have 200 milligrams of succinylcholine I wanted to give. I'm going to give and start in 20 milligram increments until I receive the desired result. And then I mentioned the acronym FOD. You're just using fentanyl as your starting point instead of lidocaine. Okay. Now let's talk about these medications here. These are potent sedatives that are capable of quickly producing unconsciousness, given IV, of course. Of course, the choices should be based on properties, side effects, and availability. Now, etomidate. Etomidate is a non-barbiturate hypnotic. Okay, it induces sleep. The problem with etomidate you got to be mindful for is patients with suspected sepsis or renal failure. Etomidate actually suppresses the hormone cortisol, which is already a problem in the patients in renal failure and sepsis, because in sepsis they're already on their way to renal failure as it is. So be mindful that etomidate is an absolute contraindication in a patient with suspected renal failure or sepsis. Versed, of course, let me back up. Etomidate is typically given 0.3 to 0.6 milligrams per kilogram, typically 40 to 60 milligrams for a normal adult patient. Versed is a benzodiazepine. Again, I mentioned it earlier. It's not necessarily a venodilator. However, it can dilate the vessels due to its relaxing properties. Also, serves as an amnesiac as well, so the patient won't remember the procedure. What thing you want to remember is that it can possibly decrease the preload, so we want to be mindful of that. Also, propofol. Propofol also can help to decrease preload as well. So you want to be sure that if a patient's already hypotensive, you want to be mindful of that. Fentanyl. Now, fentanyl can be used even in hemodynamic unstable patients. Patients with hemodynamic instability, fentanyl has a highly lipophilic value, meaning that it'll bind to the fats first. So it can still be given even if a patient's possibly on that marginal or hemodynamically stable aspect. Just be mindful, over time, of course, it can cause some hemodynamic instability. Now, ketamine. Ketamine is a medication derived from the PCP plant. Okay, ketamine is the first line for most medicated assisted routes, or even if you're going RSI as a sedative. So what you want to be mindful about ketamine is that it can cause hypersalivation. So if that's an issue for you, you want to be mindful of that. If the patient's already hypertensive, or you suspect pulmonary hypertension or head injury and they're hypertensive, has a contraindication that due to its derivatives from the PCP plant. So, but actually what ketamine can do, it can actually help to promote spontaneous respirations and preserve the respiratory musculature for patients that you would want to keep that intact. So with neuromuscular blockades, succinylcholine, the neuromuscular blockade is given rapidly IV push immediately after the sedative. So succinylcholine is the only depolarizing neuromuscular blockade. And simply what that means is when you think about a muscle contracting, okay, when we contract, we're depolarizing. And so what succinylcholine does when it depolarizes, it blocks that acetylcholine receptor when it depolarizes again. That way it cannot repolarize and keeps it in this constant state of depolarization. So that said, there can be a lot of contraindications to that, such as what succinylcholine does, it removes the potassium out of the cell and puts it into the systemic circulation. So if a patient has suspected hyperkalemia or any other things that would indicate some sort of high potassium issue, you'd want to stay away from succinylcholine, such as your multiple sclerosis, any autoimmune disorder that's affecting the vesiculatory aspect. It typically works in about 45 to 60 seconds and only lasts about 4 to 6 minutes. Okay, as with rocuronium, it achieves it's non-depolarizing. Okay, it achieves effects in 60 to 90 seconds and lasts about 30 minutes longer. Okay, so it's typically a good for initial and ongoing. Now with Norcuron, it works in about 3 minutes, and it's not ideal for initial RSI, but more for maintenance of sedation and paralysis for vented patients. The thing you want to be mindful of is to wait till the paralysis has taken effect. The urge to proceed without complete paralysis present should be avoided, because that could possibly backfire on you and cause fasciculation. Okay, jaw relaxation is a good indication of this. Okay. All right. Now with medicated assisted approaches, some patients may present with contraindications, as I mentioned, with neuromuscular blocking agents or difficult airway approaches that may want to steer you away from that approach. The MAI approach differs from RSI, whereas the neuromuscular blockade is, we're not even going to give it. It relies only on the sedatives, the hypnotics, and so forth, as I mentioned, all these medications there. Conscious laryngoscopy is used primarily to end the patient while preserving their ability to spontaneously breathe and protect the airway. Again, ketamine is a really good one for that one. Of course, when it's sufficient glottic view, conscious laryngoscopy relies heavily on sedatives. The level of sedation is similar to that used to perform painful procedures such as a fracture reduction or conscious sedation and so forth. You remember that all sedatives, opiates, hypnotics can cause some degree of respiratory depression and muscle relaxation, so be careful. Again, you can't state that ketamine enough in low to moderate doses stimulates respirations and helps to maintain muscle tone. Okay, that may be something that you want to be mindful of. All right. So with emergent intubation, that's, in other words, a crash airway, okay? Sedatives and analgesics may cause or worsen shock, especially for true opiates in pre-arrest states, as an example. Agents less likely to worsen hypotension are ketamine, etomidate, but may require reduction in the dose of the critically or injured patient. Sometimes larger doses of succinylcholine is accounted for because of impaired effectiveness and slower onset due to circulatory compromise, such as multi-systems trauma. And given IM, it can be given in larger doses, such as at 2 milligrams per kilogram listed there. Okay, so with the crash airway, sometimes it may just mean trying to get that attempt. If not, maybe your only choice is the neuromuscular blockade agent, period, because you got to remember, if it's a crash airway, they're already neurologically sedated as it is, okay? So some pitfalls, okay? Failing to prepare. Have a backup plan and suction ready. Don't forget about your suction. Have plan A, plan B, plan C, plan D, and so forth, okay? Improper ventilations. Bad BVM means poor oxygenation, gastric distension, and vomiting. That's not where you want to be. Jumping the gun on neuromuscular blockade hinders intubation and precipitates vomiting, which can result in failed airway intubation attempts and can lead to aspiration. Unfamiliarity with your equipment, okay? Be familiar with equipment. Be sure you know your med dosages, how to draw those up. In short, the principal objective in advanced transport is a well-timed and flawless airway management with no harm to the patient, okay? Let's look at a case study here. Okay, the patient is a 66-year-old female with a history of hypertension, started on Zenestril, which is lisinopril, lasted 12 to 24 hours. She has noted increased swelling of her tongues and lips. She denies chest pain, shortness of breath, cough, fever. Okay. We do note oral swelling, including the oral pharynx. She's unable to assess the posterior, unable to assess the posterior airway. She's presently alert. There's no stridor currently heard at this time, and she's sat in 100% on room air. Ouch. So this is going to be a difficult airway. Okay. Patient going apneic in this situation would be bad. Would we consider rapid sequence intubation in this patient? Probably not. My first attempt would be epinephrine. Epinephrine for this anaphylactic reaction or this allergic reaction that's precipitating anaphylaxis. And if not, possibly that's not counterindicated. If we have to do a nasal intubation, then the last ditch effort, cracking the patient. Okay, so neuromuscular blockade in this case would not be ideal. A 2-year-old with a history of pediatric intensive care admission. For asthma, she's wheezing. She's using accessory muscles. Her respiratory rate 60, heart rate 180. 84% room air. She's on maximal therapy such as your dual nebs and corticosteroids and so forth. She's fatiguing. Okay, that's indicating failure, specifically in a pediatric patient. She has decreased air entry. Okay, preparation is critical. Okay, I'm going to pre-oxygenate, give fluids, use a Roslows. She may or may not be a candidate for the paralytic. In this case, I would not choose to do so because the ketamine would probably be the only medication I do, because with this patient with reactive airway disease, we want to preserve that respiratory musculature, okay? It just depends on the circumstances. All right. Well, thank you for watching the airway management principles and assessment. I hope you learned something. After the video's over, please proceed to take the exam that's associated with it. Thank you very much.